Thank you very much, Dan, and thank you, Anat and Emily, and everybody for being here and giving me the honor of your attention and time. I really value it very much, and I hope that you will find this helpful. So I am the daughter of two Holocaust survivors, and at this point, now that my parents are deceased, I always start by showing you the only thing that I have from my parents' families. That's the only photograph that I have of my father's family. My father is that handsome young lad over there. Actually, there were more sisters in the family, and that's why the photograph survived. It's because it was sent to the one sister that was far away, and that's the only thing we have of that family. Any photograph, any object, that's it. So now that my parents are deceased, I feel that it is important for me to say, here is who they were, here is the family, I am the child of survivors. So I wanted to start by giving you an important point in the words that SAMHSA, the Substance Abuse and Mental Health Administration, put it, the trauma lens. The trauma lens, they say, the trauma can serve as a filter or lens through which a person views the world. Think of sunglasses. You put them on and everything is shaded differently. Trauma can have that type of effect on how a person perceives their world. That is so true. And what I say in my own words, and I've written about it and talked about it for 20 years, working with trauma survivors, which is my focus, I call it the dual reality of trauma, which is that people who have had terrible experiences, traumatic experiences, continue to live forever after that in a dual reality. The reality of the here and now, which is relatively safe, everybody's supposed to behave nicely, they're supposed to, depending on the type of trauma, if it's something like the Holocaust or something like other mass, we'll talk about the differences, but in any case, the parameters of the here and now are relatively safe. They're supposed to respond according to these parameters. You know, if you touch me, it doesn't mean you're gonna hurt me. If you speak loudly, it doesn't mean you're about to do something terrible to me. But underneath this, there is a parallel reality, what I call the glass floor, which means it's like, imagine, that's a metaphor that helps me think about it. This is why I use it. It's as if we lived in a world that had a glass floor, a transparent glass floor. On top is the here and now. You're supposed to behave nicely, you're supposed to behave according to socially desirable expectations and all of that. But underneath is the reality of the trauma, the reality of inconceivable things in the here and now, terrible things that happened. And so why do I call it a glass floor? Because in terms of the psychological relevance of it, we continuously, survivors of trauma of any kind, continuously live in this dual reality and continuously reference also the reality that's under the glass floor. It's like sometimes it's in the periphery of our visual field, and sometimes it comes crashing up, or we go crashing down when some trigger reminds us very powerfully of it. And there's a constant back and forth. So it's not a static thing. It's a constant back and forth. It can come to the foreground, it can go to the background, depending on all kinds of triggers, internal and external, which are invisible to other people. So I can respond from the triggered reality of the trauma. You won't even know what I responded to. My response may look very disproportionate and crazy in the here and now. So I'm giving you an example. I'm so sorry. I'm just gonna get myself a tissue.
Take the boxes.
Yeah, take the boxes. Oh, sir, very good. Thank you. Sorry. So I'm showing you some images. For example, these are images from the genocide in Bosnia. Someone who saw these things around them might look at something like this, which is a pile of branches, and for them, it brings that picture up, and that changes completely how they feel in this moment. You may think you're in a beautiful snowshoeing day, in a beautiful clear day. For them, it becomes a terrible experience in that moment. Or a patient of mine who saw their father committed suicide and by hanging himself. He says to me, I just took this from a general picture, but to make the point, he says to me, whenever he sees laundry hanging and the pens are going like this, he just goes nuts because it really reminds him of that horrible, horrible image. This is a photograph by my very good friend who's also a child of survivor and a professor of survivors and professor of physics in Israel. This is an image of grapevines, did I pronounce it correctly? Yeah. Grapevines in the snow in the Alps of Austria. Now, just to give you a sense, when I show this picture to a room in which there are Holocaust survivors or children of Holocaust survivors, you actually hear a gasp. You go like, you hear this. Why? Because to them, this is a picture of emaciated Holocaust inmates in concentration camps standing in the morning on the, on the plots where they had to stand like this in the snow for hours to be counted for the roll call in the morning. So what am I trying to show you? I'm trying to show you that the reality of the trauma is very, very present for people, for survivors of traumatic experiences. And it really, really overwhelms sometimes even the perception of reality that's in front of us. It's not only a memory in the sense that we think of memories. Memories is something we think about with a clear understanding and feeling that it happened in the past. For survivors of trauma, the feeling is that it comes right to the foreground. Not only it feels like present, but it in fact overwhelms the perception of reality, even when reality is such a simple, concrete thing as a photograph of grapevines in the snow or hanging laundry. These are concrete, simple stimuli. They are not complicated, and still the reality of the trauma overwhelms it and makes it give you an emotional reaction that is completely for something else. Now think about it. If that's what happens with very simple and concrete stimuli, what happens with more complicated stimuli, such as the stuff that can occur in interpersonal interactions, political and social stuff, much more ambiguous and much more complicated stimuli, how much more that lends itself for that kind of triggering. So let's talk a little bit about what trauma is and what trauma-informed care is. We'll talk a little bit more about trauma in a second. The trauma-informed care or a program that is trauma-informed is a program that has the 4 R's, as Samsa put it, right? It's a program that realizes how widespread trauma is. We'll talk a little bit more about it in a minute. Recognizes the signs and symptoms of it in clients. Let me give you an example of not recognizing it. When my mom was dying, a terrible death in a very un-trauma-informed situation, I was looking desperately in that day to move her from the hospital to hospice care, which is very complicated in Israel. We don't have yet hospice care for non-cancer patients. It's very complicated. There's one place in Jerusalem, it's very well known, very respected for its compassionate care. When I came there and spoke to the director, the psychiatrist, and I said, my mother is a Holocaust survivor. When she gets very anxious, she has, I was trying to explain what happens to her, and he said to me, he didn't miss a beat, dismissively, completely, that's got nothing to do with the Holocaust. That's what we call sundowning. It's got nothing to do, it's all the same for everybody. So that's not recognizing the signs and symptoms. Whereas, for example, my friend Basmat, whose father is a very respected Holocaust researcher, very, very bright man. He went into the hospital for a small operation. He had to be anesthetized for the surgery, of course. So I call her afterwards and I say, he was completely lucid. He was totally still doing his research. He was completely with it. I call, I say, so how is he feeling? How did the surgery go? She says to me, oh, you know, after the anesthesia, the Nazis were there, they were beating him, you know, the usual, because we understand it. We know. Now, he got out of the anesthesia. A couple of days later, he was back to himself and he went to get his very prestigious award that he was getting for his research at Yad Vashem. That's a fact. People do have signs and symptoms that we have to recognize. If we don't, we actually do re-traumatize them in various ways, which is the fourth R. The third R is the resist. We really hope to resist re-traumatizing our patients. So what is trauma? So I would like to show you the two aspects of the definitions that I find most useful. The SAMHSA definition talks about the 3 E's. So trauma is an event or a series of events or a set of circumstances, because some people live for a long time in a set of circumstances that are very traumatizing. So an event or a series of events or a set of circumstances that is experienced by the individual as threatening or harmful to them. Experience is very, very important because it inserts the subjective element here. Because people can be under the same circumstances or experience the same event, and one person will have found it extremely distressing and the other person not. Okay, for example, as I mentioned to you, my mother's last couple of days were horrific. I found it unbelievably distressing. It comes back to me very often in a very distressing way. My brother is completely over it. We are different. We have different susceptibilities. And the event has lasting effects on the individual's functioning in their physical, social, emotional, or spiritual well-being. So those are the 3 E's that are very important in the SAMHSA definition. As another element that we need to remember, just to kind of highlight, as I said, trauma can be not just a single event, which is an acute trauma. It can be a complex trauma, which is trauma that lasted for a long time and not just a single event. So sexual abuse, for example, any kind of abuse and neglect, we will talk about it, domestic abuse, things that last over time, those are complex traumas. And then we have, unfortunately, crossover traumas. Unfortunately, I mean, for example, what happened yesterday is an example of a tragic crossover trauma. Crossover trauma is a trauma that is indeed a single event, but it is so traumatic and massive that it has different impacts than, you know, a car accident or something like that, the more typical acute single event trauma. These are massive events that are single but so dramatic and so traumatic that we consider them differently because they have different effects. So the response to trauma is very individual and varied. And it may sound to you very obvious today, but really it is not a simple recognition. And it took our fields, the mental health professions, the psychology, psychiatry, and so forth, it took us a long time to recognize this, amazingly enough. I actually have a paper about it if somebody is interested, about our very complicated relationship as a profession to trauma, and how each time after a terrible war there was a lot of knowledge available and poof, it got forgotten. And then again another war, a lot of knowledge, and poof, it gets forgotten. So late as 70, for example, in 1970, there was a very, very famous paper by a very respected American psychiatrist in the Journal of American Psychiatry, and a very respected peer-reviewed journal. The guy said in 1970, there are no mental health consequences to the war in Vietnam in the returning veterans. And to the, yeah, I can show you the paper. Yeah, and to the extent that they are related to their childhood issues. And in 1972, he had to retract it, and he did retract it, yes. So you understand, and now, by the way, in 73, we had in Israel the worst war of Israel's existence, the 1973 Yom Kippur War. And what do you think happened to the people that were wounded in that war and to the veterans with PTSD? Same thing was said then. After he retracted his statement, same thing happened in Israel. We have a problem acknowledging and really holding on to the massive damage that trauma does cause. We don't want to believe in it, we don't want to remember it, we don't want to think about it. But we have to, because when we don't, we re-traumatize our patients. And we don't provide them with the care that they need as a society and as professionals. And that's what happened to Holocaust survivors after the war. That's what happened to Vietnam veterans here for a very long time, and in many, many other cases. So we do now recognize that there is a long-lasting effect to having survived traumatic events, and that there is a great individual variability in the response to it. Studies show us that if people are exposed to a traumatic event, there is anything between 10, depending on the situation, there is anything between 10 and 40% of the people that were exposed to the event who will develop acute post-traumatic reactions. But of those people who develop those acute reactions, about a third will recover spontaneously within the first year. A third will go on to develop the chronic disorder of PTSD, as we call it, and we'll talk about it more in a few minutes. And a third lies in between, meaning they will not have the full formal criteria required for a formal diagnosis of PTSD, but they will have sub-threshold symptoms. And I just want you to understand that studies show beyond doubt that having sub-threshold symptoms is completely sufficient to be unbelievably problematic in terms of the individual's own feeling, suffering, and the impact on family functioning and on many other aspects of the individual's functioning. So when you look at studies that talk about PTSD, you have to remember that these are just the subjects that fulfill full criteria, and there's a whole lot of other people who have sub-thresholds that didn't make it into the study, but that other studies show suffer almost just as much. So the PTSD criteria in the DSM-5 are similar to the criteria. I'm sure you know this very well, so I'm not going to go over that in detail. I will just point out to you one thing. They are very similar to the criteria before, with one very important difference, which is the cluster D, which was added, which has negative alterations in cognitions and mood, including such things as amnesia for the trauma or after the trauma, negative beliefs about the world, about self, about others, about one's place in the world, alienation, detachment from others, constricted affect, all of those things. This new cluster, as opposed to the definition of PTSD in DSM-4, with the three clusters, right? Avoidance, hyperarousal, and intrusive phenomena. That was very, very good to capture the phenomenology of acute PTSD after one event. This adds the recognition for the long-lasting, much more pervasive changes that occur in people's whole way of being in the world. And that is much more appropriate and relevant to complex traumas, crossover traumas like the people that suffered this event yesterday, this will change their view of themselves, of the world, of other people, of everything, of God, you know, their spiritual beliefs, pervasive, long-lasting changes that go beyond the 3 clusters of the symptoms of PTSD in the previous definition. So the exposure to trauma is actually, this session will be sort of more general about trauma and survivors. So I'm going to touch upon different types. The exposure to trauma, a lifetime exposure to trauma in the USA, for example, which is a pretty good place, relatively speaking, yes, is quite high. It's anywhere between 60 and 90% of people in the general population in the United States will have experienced an event during their lifetime which fulfills the formal criteria for a trauma. That's a lot. That's a lot. That means that if we are here, how many people? You know, what are we here? 40 maybe? That means that at least 4 of us it means that other than 4 of us, most likely everybody else had some kind of a traumatic event in their lives. However, not everybody will have had PTSD in their lives because of the individual variability. Lifetime PTSD is about between 8 and 10% in the United States in the general population, a little bit more for women than for men. Women are more susceptible all over the world. We see the same thing. Women are a little bit more susceptible to PTSD than men. It's surprising, but because we are, in my opinion, in many ways the stronger sex, but nonetheless, we do have a more higher susceptibility to that. It does have a very strong relationship with physical and mental health for those who develop it. So those who develop post-traumatic stress disorder are a very large minority of the people who are exposed to terrible events. Most of us are very resilient and manage to not develop it, even though most of us have some kind of an event like that in our histories. Also important to remember, very important to remember, is that PTSD as we define it, especially with the hallmark cluster of intrusive phenomena, which identifies it so well, right? Because otherwise, PTSD without the intrusive phenomena, it's not so different from other things. That's the hallmark thing, the memories, the flashbacks, the triggered sort of associations that are so disruptive, yes? PTSD with the intrusive phenomena is not the only response to terribly traumatic events. It's just one. A lot of people respond to traumatic events by depressive disorders and by anxiety disorders without the hallmark phenomenon of intrusive flashbacks. And that's very, very important to know, because when we don't see the intrusive phenomena, we often don't establish the relationship to what happened, especially if it's a distal trauma, something that happened a little bit further back. You know, the people themselves often don't establish the relationship between that and, oh, now I'm depressed, especially when it's in the past. I don't know, I'll give you a small example. You know, I have everybody in my circle of psychologists in New Jersey knows that I deal a lot with survivors of trauma, and especially with Holocaust survivors. So a colleague of mine who had a child just a little while before that, she was 40, she was one of those mature women who have children. I was also a relatively mature mom, so I can allow myself to talk about us in this way. We are a little bit over whatever, a little bit of so she calls me and she's like, you know, my daughter, she's 3 years old now, I don't know how much to go back to work, not to go back to work, you know, will it be traumatic for her, daycare, whatnot? you know, and I know you had 2 girls and you did this, and we're talking about it, and she's, you know, full of angst about the issue of going back to work part-time and how traumatic it might be for her 3-year-old child. We talk about it for a good 20 minutes, and then she says, but listen, I gotta ask you, what I call you about is my 80-year-old survivor patient. She came to me recently. She's profoundly depressed for the past month. She hasn't showered. She hasn't done anything. It's the first time in her life. She was a teacher. She was an artist. She was very active. She was very vital. Her husband doesn't know what happened to her. I say, okay, do you know anything about her past? No, I only know that she's a survivor, and she doesn't want to talk about it. She doesn't think it's relevant at all to what's happening now. I said, okay, but what do you know about her? So she said, well, you know, I really don't, but you know, she was lucky her father came back. So I said, and she was saying like, you know, she's saying like it's not so bad, her father came back. And I said, do you understand that her mother did not? And that we just talked about how traumatic it would have been for your daughter. You're questioning that her mother did not come back. Now, neither the patient nor my colleague actually established the connection to this very acute depressive episode so many years later. And I'm not saying that we'll just stay with that, okay? So, the depression and anxiety are incredibly common responses to trauma, perhaps even more common than PTSD itself. And a lot of other non-psychiatric issues are also very, very prevalent as responses to trauma, which include problems in daily living, inability to hold down a job, all kinds of things that are not psychiatric and are not necessarily accompanied by a diagnosis, but are very, very prevalent. So for example, this is from the World Health Organization document about mental health conditions after emergencies, large-scale emergencies. If you will see, severe disorders double in the population after an emergency. So if you had 2 to 3% of severe mental health disorders before, you have 3, 4 afterwards. If you had the mild or moderate mental disorders, about 10%, you get 15 to 20 afterwards, and you have a very, very high prevalence of normal distress in the population. As we said before, it's anywhere between 10 to 40%, sometimes depending on the nature of the trauma, and we'll talk about it a little bit more, much, much higher even. So there's a beautiful series of 2 meta-analytical studies that were conducted. Meta-analytic studies take a whole lot of studies about trauma survivors in disasters and mass disasters, I want to specify here. They take a lot of studies, and using a very sophisticated statistical method, combine the effects of these studies relative to the number of the people in the study and relative to a lot of things, and they come up with certain results. So they conducted a meta-analytic study of like tons of studies all over the globe on people who survive, populations that survive disasters, natural disasters and accidental disasters, and these are the numbers that you get. You get about 77% of people in these populations show specific psychological disorders after the disasters. Depression and PTSD and anxiety are the main ones, as you can see. A large percent, 40%, show non-specific psychological distress and health problems. So it's not exactly PTSD, it's not exactly this and that, it's some kind of a mishmash of some kind of a mental health problem. Health problems are seen in about 23%, chronic problems in living, as I said, in about 10%, and about 10% show a sense of loss of psychological resources, the sense that they have lost the ability to access any kind of resources that might be available for them. They lost the capacity to do that. As I mentioned before, those studies, those meta-analytic studies were conducted on populations that were exposed to disasters. But what we also found out now is very much that malignant trauma, as it is referred to, trauma that is perpetrated by people onto people with a malignant intent to harm and to hurt, is much, much more dramatically traumatic than disasters such as, natural disasters, accidents, all of those things, because it has the added aspect of really shattering our very basic belief in what people are capable of, our place in the world. We are a social species. We developed as a social species, and I'll say a little bit more about it later on. We come to the world wired to relate to other people of our species and to expect help and to expect response from other people of our species to our distress. When someone else does something terrible to us with distinct intent to hurt us and to do something terrible to us, it shatters our psychological foundation. And that's why these traumas are much, much worse in many ways. So these are just a few examples of percentages of PTSD in populations that were exposed to political violence, which is one example of human perpetrated sample. Notice trauma. Notice that in victims of torture, the extreme percent, and that's seen in all kinds of victims of torture, including Holocaust survivors. Yeah, so starvation, beatings, all of those things. Childhood trauma. Let's talk a little bit about childhood trauma in the United States. The ACE studies, are you familiar with them? I just want to know what to sort of, so it was a very large study conducted by a very large insurance company, Kaiser Permanente. They wanted to see the relationship between childhood adverse experiences in childhood and health in adults. And what they saw is quite dramatic. So the ACEs, the adverse childhood experiences or events, include physical abuse, sexual abuse, emotional abuse, neglect, parental substance abuse, parental mental illness, spousal abuse in the home. These are the main categories of the ACEs that were looked at. And more than any other, physical and sexual abuse in childhood were associated with much, much greater and much, much more lasting effects in adulthood on many aspects of, what's this?
I'm sorry.
Oh.
I didn't even realize. Set an alarm. Trying to be more on time.
Yeah? No problem. So, as I said, malignant trauma, when it's interpersonal trauma, is much more damaging, and so physical and sexual abuse in childhood are the most bad, the worst events. These are some of the percentages of that were observed in the studies. These are all available online. If you do ACE study, you can find it. And the frequency in the United States is actually quite troubling. It's quite high. The 2009 report, because these studies were conducted many times again and again to see how things change, overall there is about 60% of respondents in the general population that represents the United States general population report at least one ACE. And the problem is that as soon as you report one, you are very likely to have more than one. which we can talk about. But so this is a really, really troubling thing because, first of all, in some less privileged pockets of the population in the United States, mind you, it's a lot more. If this represents the general population, in some pockets it's a lot more. And the problem is that once you have one, you have a much higher likelihood of suffering all kinds of bad things. And since once you have one, you're likely to have more than one, that totally puts your likelihood of suffering from a lot of bad things much, much higher. For example, 4 times to 12 times increased risks for alcoholism, drug abuse, depression, and suicide attempts. 2 to 4 times increase in smoking, poor self-rated health. 50 sexual intercourse partners or more, which is a health risk behavior, yes? And all kinds of things like that. So the relationship between adverse events in childhood and all of these incredibly higher risks for later things, the relationship is very, very strong. The highest conditions related to post-traumatic stress disorder are sexual violence. Now I'm not talking about childhood anymore, but included in it. Sexual violence has the highest and strongest relationship to post-traumatic stress disorder. Combat also, so assaultive violence, and the last one is a little bit surprising and had been underestimated for many years in our field. The sudden and unexpected death of a loved one accounts for a very high percent of PTSD. So we didn't quite give it its full role in understanding just how many people actually have a terribly traumatic response to the unexpected death of a loved one. Domestic violence or spousal abuse is one of those very difficult situations associated with terrible rates of PTSD because it's both assaultive and sexual violence. Psychological abuse is also very strongly related to PTSD. Rates of exposure to trauma and higher rates of PTSD are observed in many studies amongst gay, bisexual, and transgender people. And the consequences of sexual assault, as I said, are they are associated with the highest rates of PTSD. Disasters and mass trauma, as we talked about before, large-scale traumatic events like natural disasters, like accidents that are, like Chernobyl, accidents that affect large communities, have the unique added aspect that the whole community is affected by it. So as opposed to a trauma that affects an individual or a family, and they still have the infrastructure and the services and their support systems around them, when a whole community is impacted, we have that added aspect of loss of all of that and the disruption to that. And as I said, political violence and torture are associated with extremely high rates of post-traumatic reactions, very high rates of post-traumatic stress disorder, and a lot of other people who respond with depression and anxiety. So what is the most common trauma in adults in the United States? The most common trauma in the National Comorbidity Survey is witnessing someone being badly injured or killed, being involved in a fire, flood, or other natural disaster, and life-threatening accident or assault. That's the most common trauma reported. And again, also in adults, just like in the ACE, it's interesting that once there is one trauma, there is a higher likelihood that the person experienced more than one. Just to say in brackets why it makes sense, it's because often if you already had one trauma, maybe you live in some conditions or in some ways that actually expose you to the possibility of other bad things happening to you. Despite all of what I said so far, the rates of diagnosis of PTSD are pathetically low. And we see it in many studies. We see it in Israel, we see it here, places that actually are leading in the study of PTSD, and unfortunately, in Israel, there's a long history of, focusing on it because of all the stuff that's been happening there. Now it's happening, of course, a lot more everywhere else. Still, the rates of diagnosis are very low. So we see that if you go to, studies that look at, for example, the last one in the United States, 70% of respondents with PTSD in this country, in a study, very good study, actually saw a medical professional in the 6 months before the study, but they were not recognized as suffering from PTSD. And the same is seen in many studies in different places. So that just shows you how important it is for us all to have, trainings and expose ourselves to this phenomenon, because it's much more prevalent and it's not seen. Yes, if we don't see it, we don't give it its proper place, we don't give the right attention to it, we maybe act in ways that are re-traumatizing and all of that, which trauma-informed care now tries to correct. The brain response to traumatic stress has been shown over the last 15, 20 years beyond doubt to be damaging. So there are a lot of findings about changes, lasting changes to the brain, to brain structure, smaller brains in trauma survivors when people do post-mortem surgeries. The brains are smaller. It's possible, we don't know what it means. It's possible, one hypothesis is that if you live with post-traumatic stress for so many years, and the hormones, the stress hormones levels are so high, because we see that stress hormone levels are very high, even 60 years, like in survivors of the Holocaust, 60 years after the trauma, they still have very high stress hormone levels, that this may be toxic to brain cells and kill brain cells, or that people who have, to begin with, somewhat smaller brains are more susceptible to it. I don't believe in the latter. I actually believe in the first hypothesis. In any case, neuroimaging studies show definite changes in the structure and in the function, biological, biochemical differences, such as elevated hormones related to stress, and all kinds of functional differences in the way that the brain operates, amygdala hypersensitivity, responsivity that is beyond what we see in other brains, and in children who are exposed to trauma at early ages, we see a very high overreactivity of the HPA axis, the structures in the brain that regulate the stress response. They are very, very overreactive to it for the rest of their lives, children who have been exposed to trauma. So we see then adults, or even older adults, who are incredibly dysregulated or very easily dysregulated. And I wanted to let you hear a minute of this. I have a patient who is a Holocaust survivor. She's a very elegant woman. She's a very intellectual, sophisticated woman. If you saw her, you'd see, an elegant woman. Her daughter, her only daughter, is a photographer and videographer by profession. And she said to me, I wanted to go away for the weekend. They live together in the same big house, very big house. She has an apartment. She wanted to go away. My mother was really triggered, and I videotaped for you the scene without her knowing it, because I know that nobody can believe me how bad she is when she gets triggered. I totally believe her. I've seen many things in my life so far, but I put a box on the visual, and I just have you listen to the audio of it, okay? Listen to the dysregulation.
No. Oh, mommy.
What's the matter with you?
What do you mean, what's the
You
matter
don't
with you?
have to see them, all right? You're so upset over this. You don't have to see them. It's okay.
Always, you see, I did, you did. You are doing all the
I
time.
did
I don't
not.
want to see you anymore. I disown you. I don't want to know you. Go with your friends and your people.
Mom, Please,
I don't
stop
have
this. What do you
Wait.
mean? I've been with you the whole morning. We had a nice morning. I'm trying to help you. Mama, why are you angry at me? I didn't do anything to
That's what
you.
you think. You just said to me, don't always tell me what to do.
I didn't say it to you.
Oh,
It's kind of like when you say, I hate you and I want to kill you. Was I in my...
I would like to kill you for good, but I can't.
Why do you want to kill me?
Because I hate you.
Why do you hate me?
Because you're not nice.
I'm the...
I love this lady. She's a wonderful person. She's a really unique person. Look at her. This is awful. Yes? This is living with PTSD. So, also, just to mention, the World Health Organization created, again, a study that was in 20 countries, looking at many, many different populations about the cumulative effect of trauma, and the results were very clear that there is a cumulative effect, and the threshold is quite low, if you want to look at it this way. If a person had more than 4 events, exposure to 4 events in their lifetime, that fulfill the criteria for a traumatic event as we define it by DSM-5, their likelihood of having much, much greater dysfunction and much, much greater impairment in life is very, very high. So again, if you think about people living in certain conditions in this country, if you think about people who survived the Holocaust, if you think about people coming back from combat, if you think about a lot of these populations, they have had 4 traumatic events a day sometimes for a very long period of time. This woman certainly also is an example of that. And the cumulative, so the cumulative exposure to trauma definitely predicts severity of mental health and physical health in old age, and there's a dose-response relationship. So PTSD impacts health in every possible way. There's a relationship between PTSD and just about every illness. So if you have PTSD when you're younger, your chances of having just about any bad illness later on are much higher. And this is a partial list of the illnesses that we see are more common in people with PTSD as they age. Just one second, it is not responding. Okay. So imagine if you live with someone who has PTSD, who doesn't sleep well at night, is tired and irritable, and has all of those other dysregulating moments, and anger, by the way. Anger is now, even though it's not part of the definition of PTSD, studies show, and that's a very recent, very large body of studies, that and a beautiful meta-analytic study that came out just this month in the Journal of Psychological Trauma, that there is clearly a relationship between anger and PTSD in various types of trauma, not just in combat soldiers where we knew that it's a very important element, but in all types of trauma, anger is a very prominent associated characteristic. So people living, and also, by the way, let me mention, anger on one hand, and or emotional numbing and detachment, also seen in many, many survivors of trauma. So when you live with someone like that, by the way, there's a very beautiful documentary, unusual documentary called From Hell and Back, by a guy called Dennis Danfong, and it bless you, love you. It's about a photographer, Dennis Danfong, who was accompanying a group of soldiers in Afghanistan, and then the commander of the unit got very badly wounded, and so he then, so you have real footage of him in the unit functioning before, and then footage of him back at home with his wife and struggling with his rehabilitation and all of that. It's very, very moving and very touching. So when you live with someone who has that anger, who has the detachment, all of that stuff that goes along with PTSD, you can very easily suffer from secondary traumatization. And Figley, who was the first one to coin that expression, said, you know, simply by caring deeply about someone who suffers from PTSD like that, someone who has been through terrible traumas, simply by caring so deeply about them, we identify and feel their pain. We internalize the imagery of what they've been through. It is also, in addition to that, a stressor living with someone like that. So you really also have the impact of the stressor of living with someone who is like that. So for all of those reasons, wives, parents, children suffer from a secondary traumatization. So this is just to kind of show you, I know that you don't work with veterans, but still, just so that you see some of the very high numbers of PTSD casualties that we know are around us now, and all the many more that suffer from sub-threshold PTSD and post-traumatic reactions, as I told you. So just to show you how it looks again, let me show you, some of you are too young to remember this movie, I think, the 4th of July, right? No. Born on the 4th of July. But that was, what's his name?
Tom Cruise.
Tom Cruise when he was young. Let me show you, just so that you get it, because this is like my patient. The way that he responds is really not just veterans, it's really a lot about trauma.
People help me, huh? What's the matter with you? I don't feel right. I don't feel right either. I need to see the doctor. I need to see him now!
Available.
I want to see him now! He's always too busy, isn't he?
What deep end now, Kobe?
Fucking shit!
Going up the deep end. If you take that leg, you going like
What do I have to do?
What you ever put your hands on?
Well, let's stay out because I just want to be treated like a human being. Get out of here, shit! Just want to keep me fucking close so I don't know what's going on around here, man. This is a fucking slum.
Going out, man. Fine. We take that leg of yours, we get you out of here in 2 weeks.
I want my leg.
What?
I want my leg.
What? You can't feel it no how?
My leg. I want my leg, you understand? Can't you understand that? All I'm saying is I want to be treated like a human being. I fought for my country. I'm a Vietnam veteran. I fought for my country. So I deserve to be treated for decent. Decent. I earned that right, you
Vietnam don't mean nothing to me, man. Or any of these other people. You got it? You can take your Vietnam and shut up your ass.
Go on. Go on now.
No, I don't need this.
Hey, you fuck! Hey! God damn it! I'm a fucking Vietnam veteran! Marvin! Marvin, now!
Marvin!
Every time I see it, I just am ready to cry. And really, if you want, this is, if you ever need to train someone else, to explain to someone else actually what is person-centered trauma-informed care, this is the clip for it. Because not only do you see here the response of a trauma survivor, how triggered and dysregulated he is, but you also see here, he says, you know, I just want to, he wants them to understand where he's at, what's going on with him, and the very, very additional and important aspect that is so beautifully captured. I mean, movies are amazing in this way, right? The trauma in the caretakers as well, right? He's talking about his Vietnam trauma. The other guy, the black guy, says to him, you can shove your Vietnam in the whatnot because he has his trauma and he's responding to that guy's trauma, and look what happens, how awfully hurtful, mutually hurtful, and how terrible a situation like that can be, yes? So that when we treat someone with their trauma, and we'll, you know, here I'm skipping a little bit, but it really doesn't matter, we have to be aware of how we respond from our trauma to the other person's trauma. Because we, as I said before, most of us have our own traumas somewhere in the past. Some of us are a single event trauma, some of us are, you know, more complex and sort of difficult circumstances that we lived through, and we each dealt with it a certain way, and we come out of it feeling a certain way about trauma. So some of us will come out of it feeling much more compassionate about other people's suffering. Some people will come out of it hardened, actually, like, screw you, you know? I had it at least as hard as you, or I had it hard too, and I managed, so shut up, or stop whining, or, you know, whatever, or it will actually stir our own pain, and we don't want it to be stirred, so we will not be angry, we will just distance ourselves and shut down and numb ourselves, yes? So there are a lot of ways in which our own trauma and how we dealt with it. There is also, you know, I will talk about it. Hopefully it's really important to me to get to it, so I will have to see what I skip, because there's no way I'm getting through all of this. But I really, really wanted to talk to you. Maybe I'll just bring it right in here right now. I really, really wanted to talk to you about dehumanization in treatment. And maybe this is a good place to do it. We usually talk about dehumanization of other people as something that happens under very extreme conditions. In genocide, in Holocaust, you know, concentration camps, in Bosnia in concentration camps, in all kinds of terrible places, in Abu Ghraib, you know, things that are relatively extreme. But really, dehumanization is not rare, and it happens in many, many much more benign, so to speak, situations. And what is dehumanization? Dehumanization is actually when, for some reason, we look at another person as if they are less human than us. They're a person, but you know, our mind does not actually assign a fully human status, an equally fully human status, to everybody who's another person. And there's a reason for it. So we have now a whole new field of study, which is fascinating, which is the study of neuroaffective cognitions. We have now neuroimaging techniques that allow us to see what's going on inside the brain when the brain is engaged in all kinds of tasks, emotional, you know, all kinds of cognitive and emotional tasks without going in. We can do it with just very non-intrusive methods. So it allows us to see what happens inside there. When we tell people to think about certain things, when we show them certain images, when we engage them in all kinds of tasks. And so what we see is that when people look at certain others, you know, there is a part in our brain that is exclusively dedicated to social cognitions. It's exclusively dedicated to categorizing and responding and evaluating other people, not objects. But certain people are not processed by this part. They're processed in a different part of the brain, which is not dedicated to social perceptions. It is actually for objects and some people. In other words, it's an indication that the neural processing of certain people treats them like objects, more like objects than like people who are strictly like us. And there are several parameters that put certain people at risk to be treated more like objects than like people. What are those? And these are very relevant, I think, to our work. One thing is if the person has a mind. Our brain, first of all, looks at the world around us and differentiates between people and not people. First of all, is this a person or is this something else? That's a very important immediate categorization that we do as we meet any kind of something. Yeah? So, first of all, does it have a mind? Now, if a person is a person, but they are a very cognitively impaired person, or, you know, I will give you an example. My aunt lived to be very old in Israel, and she was in a nursing home. And I remember once she was in a room, she was sharing a room with another patient, and she was still interactive and whatnot, and the other person was this huge, big, fat, bloated mass that lay in the bed and was completely unresponsive anymore. She was ugly, she was, she had no hair, it was awful. It was this mass of organic matter in the bed. When someone is like that, our brain does not necessarily categorize that as a person. Because once we kind of sense that there's no brain there, there's no mind that is fully working, a good example for that somebody remembers the movie with Paul Newman, the most handsome guy ever. Paul Newman, Where the Money Is. He was old already, but boy was he handsome. He was old, and in the beginning of the movie, he's a robber, a bank robber, that was finally caught after 30 years, a very good bank robber, finally caught, put in prison, and then he has a stroke in the prison, and he's put in a long-term care facility. And there, he pretends to be kind of really, really cognitively impaired, and actually turns out he's not. But if you watch the movie, which is just a fun movie to watch, by the way, if you watch the movie, notice your own feeling about Paul Newman, even though I told you already the thing, so it kind of spoils it a little bit, but notice your own feeling when you see him in the wheelchair, like this, and there's a bug that's walking up on his face, and he's not responding, and he's drooling. Notice your own response to him then, and your response to him later in the movie when he's his handsome, charming self again. Completely different, yeah? So our brain does that first of all. Does it have a full operating mind or not? People who don't have a fully operating mind are at risk to be perceived more like an object than like a person. People who disgust us evoke in the brain the kind of processing that is more like an object than a person. Now this is very important to us, and it's very important for me to talk about it in all of my presentations, because we work with disgusting people sometimes, and we might as well actually talk about it. When people come to us who have behavioral problems and PTSD and issues, elderly people, not elderly people, but illness, neglect, behavioral issues create a lot of stuff that's disgusting. People can look unclean, people can smell badly, people can have moles, they can have hair where they shouldn't have hair, they can have no hair where there should be hair, they can have wounds, they can have all kinds of things that are disgusting. And our brain is a creation of many, many years of evolution. And we now have a very strong emphasis in behavioral research on the impact of evolutionary psychology. What did evolution teach our brain? Evolution taught our brain that if something is disgusting, maybe it's not good for us. We should stay away. It is not clean, it is sick, it is not good for us. We should stay away from it. So that's one of the reasons why when we see these things that are signs of decay, illness, age, we have that gut reaction, which is really an evolutionary triggered reaction. So if somebody has those things, they are likely to evoke that reaction, and that reaction puts that person in our brain in a place of less of a person. And also, if the person looks very different from us, think about it. In our evolutionary roots, we lived in isolated tribes. And the tribe people looked all the same. And they look different from other people that lived in faraway, isolated tribes. And in our evolutionary roots, we had to have very, very strong and rapid automatic categorization processes that will keep us alive. Because look at us. What are we in comparison to a tiger? What are we in comparison to whatever else dangers were in the physical world? So first of all, we had to be very, very good at communicating with our own tribespeople because we needed to read each other very rapidly, to work cooperatively, to run away from the tiger. If I saw fear on her face over there, I need to understand it already and respond. Or if we all need to work together, we need to understand immediately what we need to do, right? Like sometimes I do something in the kitchen and I'm doing it and my hands are tied and I'm doing it with one hand and my husband is standing there watching me. I'm like, can't you get me? Like, you know, so that's an example of not so good intersubjective capacity. But in general, as a species, we can read each other and know what's going on. That's with regards to the physical environment, but we also had to read the interpersonal environment in the sense of quickly recognizing the difference between potential friend and foe. Because people who look like us were more likely to be favorably inclined to us, whereas people who looked very different were very likely to be a source of danger. So that worked well for us then. But now, in our very multicultural society, look around the room now that we live in a very diverse society, it doesn't work so well because all of a sudden, I'm looking at a person that looks very different from me. My brain takes many, 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 many thousands of years to change. So my brain is still saying to me, oh, this is not exactly like our kinsman, but it no longer is relevant to our society today. So we need to be aware of these things because we actually have the capacity. It is not an intellectual exercise. It doesn't help our brain if we tell our brain, listen brain, you know that this is not right, so do something different. That doesn't work. We have to trick our brain to overcome dehumanizing perceptions of others. And we can trick the brain amazingly simply. All we need to do, bless you, is to focus on shared group membership instead of what is the difference. So if you look very different from me, and I feel that feeling, or I know that I might feel that feeling because you look really different from me, I have to focus intentionally in my brain on our mutual group memberships. For example, hey, we're both mothers, or we're both mental health professionals, or we're both interested in I don't know what. As soon as my brain sees you as in my in-group, it kind of does the opposite. It brings it back to, we are in the same group. You are in my in-group. And if someone is disgusting, we also can do things like that in our brain. Or if someone is, forgive me, we said no mind, okay? If the mind is impaired or the mind is not there at all, okay? We can focus on that person's mind, even if the person themselves have no mind anymore. As soon as I ask myself, I wonder if this person liked broccoli or cauliflower. As simple question, I wonder what this person's favorite holiday was. I wonder if this person, who loved this person? You know, as the older I get, the more I value my mother's wisdom. And she was not a woman of a lot of words, unlike her daughter. But she was amazing. So she sometimes, when we would see someone really dilapidated or whatever in the street, if I walked with her, she would say to me, Irush, remember, this person also had a mother and she loved him. You know, as soon as we think about this person's mind, this person's relationship, who did they love, who loved them, and even as simple as what was their preferred food, or holiday, or sports, or whatever it is that's meaningful to you, as soon as we in our own mind think about their mind, they move in our brain to be processed as a person and not as a thing. Same with disgusting, people who are disgusting to us, yes? So that's a very, very important lesson, I think, for us as mental health professionals, as people who work with people who are sometimes very different, who are sometimes very impaired, who are sometimes very disgusting, either by their physicality or by their behavior because of PTSD and all of that. We need to maintain our humanity and their humanity by recognizing the value of these lessons from academic research. Yes? Okay, so back to where we were. Anger, I said, it's a very prominent characteristic of PTSD. As you can imagine, this guy, Vietnam veterans, 40 years later, they don't look so good as a population. Their relationship, their social, their interpersonal, their physical, their mental health as a population, they don't look well. And their functioning, combat veterans' family functioning, as we can imagine, is very bad relative to others. And we have seen also that it is true not only about combat trauma, but about trauma across populations. Family functioning is impaired and often impaired, not in everybody, but is often impaired in trauma survivors of all kinds of traumatic experiences, not just combat. This is an important point that I want to make more for your lives than for anybody else's, but still keep it in mind also in terms of our patients, that one of the things that we see is that couple intimacy, in plain words, sexuality in the marital or partnership bond, sexuality is specifically impaired in trauma couples. So, and it's got nothing to do, I'm not talking here now about emotional closeness. We know that that also sometimes is impaired, but specifically sex. So even couples in which one spouse has PTSD, but report a good relationship and a closeness, even in them, there is a specific impairment of sexual functioning and satisfaction. So, you know, there is a hypothesis that just like PTSD in individuals has certain ways of showing itself, that it also has certain ways of showing itself in the couple with a specific damaging impact on sexuality. It is also important in the context of secondary traumatization in the couple, because think about it. Now you have perhaps somebody, a wife or a husband, who has lived with a spouse who has some degree of PTSD, which is difficult to live with, who now has also some problems in sex that have been there for many, many years, and it's very frustrating. I mean, there are studies that really capture it very well. There are support groups of women whose husbands are veterans in Israel, in here. It's a very big problem if, you know, your husband kind of lost interest for many years, or your wife lost interest for many years. And we know that in general, in couples, you know, that sexual satisfaction in the marriage, when it's all good, it explains about 15 to 20% of the variance between couples in terms of how satisfied they are in general from their marriage or their partnership. But when it's bad or non-existent, then it explains 70% of the dissatisfaction from the relationship. Which means that when we see a couple where there was a problem or there is a problem in the sex, it's something that we need to address in and of itself, which is a whole different conversation that I won't get into. But in terms of secondary traumatization, you may be looking at a couple that has had all of these problems in their relationship for a very long time by the time they come to you. The impact on youth in the family has been shown across many, many types of traumatic experiences, how it impacts when there's parental PTSD, how does it impact the children. So the spouse's severity of symptoms impacts each other. So even if one has the symptoms, it impacts the symptoms in the other. The other unexposed spouse can develop symptoms of PTSD by identification, internalization, like we said before, but also other things, just because it's so hard to live with this person. And the more anger, hostility, paranoia, detachment there is in the spouse with the PTSD, the more symptoms the other spouse will develop, clearly, right? And the more symptoms there are in the parents, the more problematic the impact will be on the children. It kind of makes very, very much sense, right? And there will be, children have been shown in many, many studies to be very sensitive to the discord and conflict in the family due to PTSD. So, and we see it, so now we talk, a lot of the studies originally about the impact of PTSD and parental trauma on the children. A lot of the studies began with children of survivors of the Holocaust. And in the beginning, the studies were not quite so methodologically great. This is a field of expertise of mine, so I could talk about that for 17 hours. But in the beginning, the studies were not so good, and then the studies became much, much better, and definitely showed that there is transmission. Is it okay if I ask for a bottle of water from outside? Oh, great, great. Thank you, thank you, thank you very much. Sorry. So, over the many years that these studies were conducted, we have a robust body of knowledge that shows that there is transmission of parental PTSD, effects of parental PTSD onto the children. We call it now historical trauma. The way that parental trauma and even great parents, grandparents and great-great-great-grandparents, we now know that these effects really do transmit in families in many kinds of populations. So this is a series of studies that were done on children of survivors of the Khmer Rouge in Cambodia. That was a terrible, terrible time in Cambodia in the early 70s, bless you, mid-70s. And Field, in conclusion of a series of those studies of the children, stated, parents who suffer might communicate their emotional vulnerability, instilling inordinate concern in the children for their welfare. And we see it in many different populations. So historical trauma was now shown in many populations. I'm mentioning just a few there, and it goes way beyond the second generation in a family. It's not just the children of survivors, it's also the descendants of survivors of various types of traumatic experiences. So how does it happen? It happens essentially because trauma in the parents interferes with what we consider parental competence. Parental competence being the capacity to be there, to be attuned to the, appropriately attuned to the child, where the child is, to the developmental needs of the child, to the mood of the child, to whatever the child is, because you are either emotionally detached and numb, because you're trying to hold back your trauma, or because you're too easily triggered. So parents are experienced as either too closed off and unavailable, or too overreactive, over anxious. Don't go, don't do, don't this, why did you do this, flying off the handle. In either way, they don't have the appropriate capacity to provide the child with the kind of guidance and also permission to explore and develop a trust in their own capacity to do things appropriate to their developmental level, right? They're either held back by the parents' anxiety, or neglected, or overprotected, and so forth. So that creates a certain reversal of roles where children are often very inordinately aware of the parents' sensitivities and develop in ways that are according to the parent's sensitivity. So let's not trigger the parent. First of all, the mere fact that a child, instead of being able to freely develop the way they want, the way they are, the mere fact that a child has to develop continuously sort of checking where the parent is. I don't want to trigger my father. He's going to get upset if I do this. I don't want to upset my mother. If I have a patient who describes to me in Israel that at least the environment, there were many, many Holocaust survivors, right? So the environment was supportive to children of survivors in many ways because they weren't alone, they weren't isolated. So there were certain norms that helped us do what maybe was helpful. So for example, my patient Yochi, who's an Israeli, describes to me how her mother, who was had very bad PTSD, every year in Israel, the school class goes on a trip for 3 days. It's a very nice experience. You go, you do. Well, every year before the Tiyul Shnati, before the yearly thing, for a week, she would say, I want to go to on the trip, and she would cry the whole week, and her mother would cry the whole week that she doesn't want her to go. And what are the two outcomes of that kind of a situation? Either the child doesn't go, like many people that I know, because they just can't bear to cause their parents such suffering, since they are, as Field said, so aware, inordinately aware of their parents' suffering and all of that they've been through. Or the child can go to the trip, but at the cost of internalizing a sense that I am cruel, I'm selfish. It comes at the cost of my mother's crying there for 3 days and going like this for 3 days and not sleeping until she'll see me back. So my pleasure and my expansion into the world comes at a very high cost, and that creates its own lifelong issues. So what I want you to see is, how does it happen? How do kids get it? How do kids get this stuff from their parents? And we are very, very aware now because, again, we have new technologies for research in every field, including the field of interactions between mothers and infants, yes? So we have now video technologies for the past, 20 years or so, and we can videotape the interactions between mothers and infants in natural play, and cut it every so many seconds. And that allows us, if you have a camera on the mother and a camera on the infant, and they're interacting, if you cut it at a second, each second, it allows you to see the dance between them in a way that the eye doesn't perceive. And they're beautiful things that you can see this way. And there's a beautiful book by my colleague Beatrice Bibi. She took those photographs from her study, and an illustrator illustrated them instead of the photographs of the real people. And you can see how coordinated the responses of very young infants and mothers are. It's Beatrice Bibi, it's her book, I don't remember, but it's a picture book. So if you Google picture book Beatrice Bibi, you will see it. So the role of micro-interactions and how the child grasps it is beautifully seen by this. Anybody ever saw this or another example of the still face experiment? How many? Okay, so maybe I shouldn't show you this? Show it anyway? Okay. So it shows you how sensitive little children are to some break in the attunement of the parent, a break which is either because the parent has a PTSD moment where something reminded them of something, and for 2 minutes they're kind of in their own world, or a parent who's depressed, and for a couple of minutes or more, they are unavailable and in their own head. So in the still face experiment, it's a simulation of what happens in such moments.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment that the mother did was she sits down and she's playing with her baby who's about a year of age. And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she points. The baby puts both hands up in front of the table, says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing. It's a little like the good, the bad.
See? And it's those micro interactions that actually continuously occur between mother and child, mother who's depressed, mother who has PTSD, or father, and they create the dance between the two of them and what the child perceives as, when does it do this, when I do this my mom kind of goes away, or when my mom goes away, how should I sort of respond to it, what do I do with my feelings in that moment, what do I do to prevent, I mean, people describe triggering their parents, you know, people describe all kinds of things, and they learn not to do it as best as possible because it's very aversive. So, for example, another scene from an older child, this is a child of survivors, and a scene about such a micro interaction for a slightly older child. And you see, this is good parents, right? Father has a warm relationship with his son.
Just a little bit over there.
Look, everything is nice between them, warm.
Hey, what's this? Is an apple food? Why do you throw it away? Can you imagine? Take it. Take it! During the war, everything had value, no matter how small. A button, a pencil, a spoon. Not to mention the things that could make you weep. A good pair of shoes, hot water, a scrap of food. It's not right, Jacob. Now my own son throws away an apple.
Yes.
You see, this is a father who survived the Holocaust in a concentration camp, and that's his response, and that's the kind of thing that happens. Small responses like that that color the interaction and infuse the relationship with this understanding that is not a knowledge of the Holocaust, it's not an informational knowledge of the trauma that the parent went through, whether it's Vietnam or this or that. It's not the facts. In fact, oftentimes, the children of survivors don't have a good, survivors of any trauma, don't have a good story narrative in their minds of the actual timeline of the events that happen in their parents' life, because the impact of the way that it's told is so emotionally overwhelming, and the way that it impacts the child is so emotionally overwhelming that it kind of disintegrates cognitive processes that are associated with creating a very orderly narrative. So it's not an informational knowledge, it's a relational knowledge. It is an experiential knowledge that comes through the relationship with the parents through all of these micro interactions. Or if you like, this is another example from a book, Mouse by Art Spiegelman. In short, we get the intergenerational transmission of parental experiences, which is actually an experiential knowledge of things that happened before we were born. Yes? That comes through little things, half nonverbal reactions, that happen all the time through the relationship with the parents, and create this. I love this picture, because this really, in art, there's a way of showing us very complicated concepts. This is a guy who went to the Jewish quarter, the abandoned Jewish quarter in Berlin, and he found old pictures, photographs of life in the old, in the time before the war, and he projected these photographs life-size on these buildings. And it tells you in a very clear way something very important about the intergenerational transmission of trauma, because this is the memory of the second generation, of the descendants of trauma survivors. It's as if it's there, but it's not there. It's kind of, it's both there and not there at the same time. It's something you remember, something you feel, something you really sort of have inside you, which is really not it's not really there anymore, and you weren't there when it happened, but it's there for you emotionally and experientially. Now we have 15 minutes, and I am at like slide 58, and really, you know how many I have? 142. So, but I knew it, and so what I want to know is if you would like me, let me look here for 1 second, okay? If you would like me to speak about a little bit more about delayed onset of PTSD or PTSD in elderly, and okay, and also in the end, I had all kinds of neat things that we can do with elderly survivors of trauma, even those who are cognitively impaired. So these are neat things. So I'll try to skip kind of quickly. So what we know about PTSD, as I said to you before, PTSD impacts people throughout their lives in various ways. Heightened stress hormones, all of those things, health issues, and so clearly we are much more likely as healthcare providers, whether physical healthcare or behavioral services care, we are much more likely to meet people who have been exposed to trauma and have had PTSD or other post-traumatic symptoms than in the general population. Because all of the troubles that they've had throughout life because of it will make them age less well. There was a beautiful conference about aging in Geneva where somebody said very beautifully something like, we have to have a lifespan perspective on aging, she said, and she said what it means is you will age the way you lived. You will age in a way that will reflect the things that you've encountered in your life and how you've lived your life. And if you've encountered terrible things, it will change the way that you age. So the aging as depicts depicted in a very beautiful way by Tuesdays with Morrie, who read Tuesdays with Morrie, right? That's a guy who had a good childhood, a great life, a terrible end, but the way that he can take it is so resilient and so positive because he had all of that. Trauma survivors who have dealt with all of the bad stuff that this caused will age often in a very different way. So PTSD can have different courses over life. For some people, they can live for decades symptom-free or with very, very minimal symptoms. They can use a lot of thought control, distraction, be very, very busy building their lives, looking ahead, thinking positive, trying to make life better for their own children, you know, all of that, and relatively keep the symptoms very low with that for a very long time until they grow older, and all of a sudden they are weaker, they don't have the physical capacity to do all of that, they lose a lot of their social roles, so they don't have where to distract themselves so much, and there's a lot more time and a lot less ability to use all of these distracting methods, and then stuff comes up. Also, don't forget, old age is associated with many losses, normative losses. You know, we lose, as I say, social roles, our children move out. For trauma survivors, this is often the focus of their positive thinking and their, energies is their children, and that all of a sudden the children don't need you so much. So like my patient said to me just 2 weeks ago, what am I here for? What am I here for? Who needs me? Nobody needs me. What am I here for? So those losses, not to mention losses of one's own health and real losses of spouses and siblings and friends and all of that. So all of that, of course, is part of why older people who had traumatic losses or traumatic experiences are much more likely to do that. Also, I'm sure you understand the interaction between normative processes of aging, which involves reminiscing and creating that, peace with our own path that Erickson called the achievement of integration, right? That we have to sort of accept our path, the mistakes, the bad things, but it's okay, it led me to who I am now, I'm in peace with that, it's okay. Well, it's a lot easier to do that. Let's say what you have to deal with is, well, I wanted to be a doctor, but I didn't become a doctor, I became instead a PhD nutritionist, and or, well, my first marriage was awful, and it was really bad, and I spent 10 years in a really bad relationship, but because of that, I came to this town, and I met my husband, and my second marriage is so much better, so I can make peace with these things that I didn't achieve, or the things that were bad, but led me to where I'm at today. It's much, much harder when people have terrible trauma in their past. They can't quite say to themselves, well, it's okay that I was sexually abused by my father because it made me be, a mental health professional who can help other people. It's great that you are a mental health professional who can help other people, but it's really hard to make peace with that and so forth. So that's kind of understandable, right? And the problem is that all of these older adults who had either ACE, childhood adverse events, or this and that, all of those people, political violence, growing up in circumstances of poverty and danger, ongoing, all of those adults are at risk for PTSD in the older age. It can be, like I said, even people who didn't have it, who managed to have minimal or none for decades are at risk for it. Other people maybe had it a little bit, but it will get exacerbated. And then, of course, we have those who from the beginning had these lasting, pervasive impacts, and they were difficult, and they lived a difficult life all along, and now they're even more difficult in their old age. So those are various types of courses of PTSD. Unfortunately, like I said to you, PTSD is underdiagnosed in the general population, and it's even more underdiagnosed in older people, often because of several very obvious reasons. One, the trauma that is now causing this person the depression or the anxiety or the PTSD is so far in the past, like with my patient, my colleague's patient, yes, the 80-year-old who, it's so far in the past that the patient themselves don't think that it's related, you don't think that it's related, unless you do trauma-informed care, which requires that we ask specifically about traumatic experiences in the most gentle and appropriate way, which we will talk about another time. But we have to ask, because otherwise we won't know, because the patient themselves won't even establish this relationship to what we call the index trauma, yes? So first of all. Second, we kind of tend to think that old age is, it's depressing. It's depressing. So if we see a patient who's old and they're depressed or anxious, we're like, oh, well, the husband died, the children moved away, they have nothing, it's depressing, what can we do? Or the person is anxious, well, you're old, everything is hard for you. We tend to take it as if it's normal, and I want to impress upon you that the studies show very clearly it is not normal to be depressed or anxious in old age. It is prevalent, but it's not normal, and we should not accept it as, okay, what do you want, And there is treatment for it, and they can improve with the appropriate treatment. And there's a very beautiful paper by Dan Blazer, a very famous psychiatrist who treats old age people, depression in old age. I can, by the way, forgot to say, see this here? Please put your email address for me here if you want me to send you a message that will allow you to click that you accept or don't accept being on my blog, where you can get access to all kinds of materials and to lectures that are already there, or all kinds of things. And so, Dan Blazer, depression in old age in terms of the pharmacotherapy of it. So we will skip this and say, working with elderly people is not for sissies. Really not, because, it gives us a preview of what it is to be old what it is to be old in general, which is definitely much less fun than being young, and what it's like to be old in our society, which is also not necessarily the best. And when you talk about people who have been through terrible traumas, it's even more difficult, because then you have a compiled impact of having to deal with often terrible child abuse, child trauma, really sadistic experiences that people went through, and now they're old, and you have the feeling as a healthcare provider, that there's no time. What can you do already? The life was lived, the options were made. What can you do? And it's very, very upsetting for us, because what are we all about? We're about helping and doing things and changing, helping people change things, and they can, which is another very, very big danger, why we might inadvertently and non-consciously distance ourselves from these patients, because it's too upsetting to us to feel that helplessness, to feel that kind of hopelessness, and not be very engaged. And indeed, studies show that providers, in this case of elderly trauma survivors, can be either over-involved or distant and kind of, this is too upsetting to me to be so hopeless and helpless and all of that. So we have to be aware of that, and we have to work with our own feelings. And I think this is the most important thing that, since we have only 5 minutes, I will stay with that. We have to work with our own feelings is the main important concept, in my opinion, from trauma-informed care. Sure, we have to be aware of the patient's trauma. Sure, we have to be very respectful of that. But we also have to be aware of our own traumas, our own responses. By the way, we can also dehumanize up, as it's called. We don't only dehumanize people who we see are below us, we can also dehumanize those who we feel are haughty, and think that they're above us, they had more opportunity, they were more privileged. We can also dehumanize up, and as the people who showed that, as they said, Fiske is one of the researchers who does a lot of work on dehumanization, and she says, envy is harm waiting to happen. Yeah? So when we see a patient like that, it's like, oh, sure, he had millions, and he had this, and I had to work so hard to get to where I'm at. If you feel that, that's also a form of dehumanization. And again, we have to focus on the person, the joint, the things that are mutual, the things that are shared, to overcome that too. So I think that, as I said, one of the most important points in trauma-informed care is not only the awareness to the patient's trauma and to our trauma, but also the permission to understand that working with trauma evokes very complicated, difficult feelings in us, to give ourselves permission to feel it, actually, because only if we feel it and if we acknowledge it, then can we do something that will truly counter these processes in our brain, and not just surface level, cognitive, intellectual stuff, but really from the heart. And the other thing that I want to mention is you have to recognize that these trauma survivors that you work with also have tremendous resiliencies that allow them to get there. And there's a beautiful paper about it called Working the Double Edge, which is about trauma, survivors, lessons that were taken out of in-depth interviews with 20 survivors of complex trauma, that show what we need to be aware of when we come to offer help to such survivors. How do we recognize the double-edged side, the two sides of their, often the trauma adaptations that people created are both the source of their pathology, but also reveal their strengths, their strengths that they used there. And we can focus on those things to actually try to work with that double-edged, kind of perception of the strengths that are embedded in what nonetheless are pathological adaptations, but have the core of the person's strengths, and how to use it actually for recovery and for better adaptation. And finally, I didn't get to talk to you about specific ways that we can work with elderly patients, trauma survivors, even those who are cognitively impaired. But the message is they can. I can share with you a lot of little things that come up in the literature. If you give me an extra 5 minutes, I'll show you a really nice video about snozzling. Who knows about snozzling? Okay, you have to give me 5 minutes to show you that. Okay, just 1 second. So before snozzling.
Just the way I've read the book, which I can give.
Yes, and I also would like, before you leave, I would like to show you several resources that I want to use with you, which I can share with you if you want. Whoever wants, I'll send it to. But what I wanted to say is, even with the very impaired, we have to use, and we can use, when we look at this double-edged perspective, what kind of resilience, what kind of strengths do we see in anybody? Even somebody who's very impaired has something. So there's a very well-known famous story about Milton, what's his name? Erickson, the story of the lady with the violets. Do you know the story of the lady with the violets?
No.
Yes?
No.
Okay, so it's a story that somebody asked Milton Erickson to go see this old lady that used to be, more social and everything, but now her husband died. She lived in this big house. She barely came out. Nobody saw her. She wouldn't open the door when people came. I don't remember how she got her groceries, but she was really kind of in a not good place and whatever. And she was also physically very not well. So she didn't have good mobility. And he went to visit her. She was very depressed, and she was no, like they are, nothing is, she can't do this, she can't do that, she can't do this. But he noticed that on the windowsill were a whole bunch of potted African violets. So he asked her about the potted African violets, because this was something that obviously was nice and pretty, and she must take care of them if they're alive, right? And that was something she really liked. She took care of her African violets on her windowsill, and she made new ones also every once in a while. So Milton Erickson said she also used to be very fond of her church, and but she stopped going. So the bottom line of the story, to make it short, even though I could make it nicer, is he said, you know, it would be really nice if you could make violet plants for this person who's getting married next week, whatever. He got her, in short, to start making cuttings, African violet plants, for people who were getting married in the church, and later for people who are having, I don't know, babies or whatever. And it became her thing, and people would come to visit and to thank her and this and that. By the time she died, there was really a notice in the newspaper, a big one, about the lady with the violets and how everybody appreciated her and how connected to the community she was. Now, this is a prime example of person-centered, trauma-informed care, because person-centered also maximizes the natural resources that the person has. That is her connection to her church. He kind of grasped on that, and encourages the community connections, which he did through the violets. This is a perfect example. Now, to show you, and this is a woman who barely could move, barely could get out of the house, but it became such a good strength-focused, intervention. So, show you a video about snozzling, and with that we will be done. Before that, I want to show you, this is a brochure for caring for Holocaust survivors with sensitivity at the end of life. But all of it was based on a day workshop that I did for MJHS in New York. It's available online for free. The end of life piece is really just in the very end. Everything in the beginning is appropriate for you to read if you want to know a little bit more about caring for Holocaust survivors. There's also a beautiful training program, if you want, by a colleague of mine from Australia, Renee Simons. And I want you to be aware of the SAMHSA documents, especially the one about person-centered trauma-informed care. It's called Trauma-Informed Care Resources Guide, which I think Anat may be prepared. Okay, if not, I can give it to you. These are very, very important resources, and like I said, I'll be happy to share with you any of the articles that I mentioned. Just please put your email and let me know if you want to be on the blog, and if you want something specific that I mentioned, send me an email about it. And now I will show you a video about snozzling, which is a very easy to implement thing, both in the home of the elderly patient or creating a room like that in your agency.
The word snoezelen comes from two Dutch verbs, snuffelen, to sniff and explore, and doezelen, to relax. Snoezelen therapy, or multisensory environments, has its origin in the Netherlands, where it was first introduced with children with autism. More recently, snoezelen therapy has been brought here to the United States to be used as a new therapeutic modality with residents with dementia. Let me introduce you to our multisensory environment. Residents with dementia often have agitated, restless behavior. We find them picking at their skin and sometimes making lesions on the skin, picking at furniture, picking at clothing. As a way of diverting that energy, we'll bring them into the snoezelen room and allow them to interact with the fiber optic spray. The spray changes colors automatically, which allows the resident to interact both visually as well as with the sense of touch. Symptoms of lethargy, poor energy, no motivation are often symptoms associated with dementia. In an effort to bring our residents out of their rooms to interact in their environment, we bring them into the snoezelen room to stimulate those senses. by use of environmental sounds. We use our birds, photos of water, of nature sounds, and nature images to intrigue the senses and cognitively stimulate the residents. Short-term memory is lost with dementia, but oftentimes long-term memory remains intact. Therefore, one of the things that we use the snoozle room for is to try to stimulate or cue that long-term memory, perhaps by use of a familiar object, such as a bird, where residents might be able to relate and tell a story from their past related to bird feeders or bird watching. The bubble tube is probably one of the most popular items here in the snoozling room for a variety of reasons. Many of the residents enjoy interacting with the bubble tube because it's a cause and effect. They can actually create change in their environment by pressing the colors on the wheel and making the tube colors change. In addition, many residents will sit next to the bubble tube for a long period of time, experiencing visually the changing colors, but also having a sense of tactile stimulation by touching the tube and experiencing the vibrations. Research has begun to examine the role of projected images, how the brain interprets those images, and what effect that has on our emotional system. Not surprisingly, these results reveal that images of a more calm, serene nature tend to lower the heart rate and lower the blood pressure, as opposed to images that are more cognitively complex, such as animals in a forest, where the mind has to pay attention to details. These images tend to be more stimulating and create more alertness in residents who may already require some stimulation. As dementia progresses, often residents lose the ability to communicate through language, leaving them only with their senses as a way of interacting and communicating their needs.
So this is, there's more to it, and there's another very beautiful one which I could share with you if you want. I think that we will have to stop here. I thank you very, very much for your attention. And